Good morning, everyone. I see that there's still lots of people joining us, but I want to get underway in the interest of time. So welcome to the webinar. Today's topic is understanding the connection between sleep and your health. And we are very delighted that all of you have joined us. As many of you know, these complimentary monthly webinars are brought to you through a collaboration of sponsors, and they are Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And my name is Kim Bailey. I'm a program and education specialist, and I'll be your host today. Our sponsors are providing these webinars to you as a service to the community, and they're on topics that are beneficial for anyone who cares for or works with older adults. And I think that you're going to find today's presentation especially informative and useful. Our presenter today is Dr. Ruth Benka. And before I introduce you to her and tell you all about her, I want to tell you what you need to know if you are earning continuing education credit, CE credit, for today's webinar. So CE credit is available for RCFE, NHAP administrators, both of those, and then BRN, which covers RNs and LVNs, and also CAMP through the Board of Behavioral Science, and that's for LCSWs and LMFDs. You must be online for full 60 minutes in order to receive your CE credits. You must have access to both audio and visual on your computer. There will be a series of poll questions throughout the presentation, and you must answer those immediately. This is not so much a knowledge check, more proof of your active participation. So I want to stress that if for any reason you have trouble with the technology and find yourself unable to, for example, click the submit button on these poll questions, then you can put the answer into the chat box in your control panel. But you must answer the poll questions for your CE credit. There's also going to be a survey that you need to answer right away. That survey is going to open up when we close out at the end of the webinar, and you'll also receive it on email. And so that has to be submitted within 24 hours so that we can get the certificate sent out to you in a timely manner. Let's see, what else? Basics for everyone. As I've mentioned, you're able to print the handout, which is actually a copy of the slides, from the control panel at any time during the webinar. If for any reason you get kicked out of the slides or when you're printing the handout, or if you lose your way during the webinar, you may notice the little blue flower on your taskbar. You can click on that. That will get you back to your slides. All of you are automatically placed on mute, and you'll remain on mute throughout the course of the presentation. However, that doesn't mean you're not able to ask questions of our presenter today. You can do that by typing your questions into the question box, the chat, and we're reserving time at the end of the webinar for, we'll have a Q&A with our presenter. So once again, that survey is going to land immediately after the webinar ends, and that is going to be sent to you on a follow-up email an hour later, and that must be completed for you to get your CE credit. And in the next slide, I just have a screenshot to show you the control panel. Let's take a look at that, just in case there are some of you who are new. Also, if you might want to hide the control panel during the presentation to have full visibility of the slides, you can do that by clicking on that orange arrow. Again, there's where the handout is located and the chat box where you can type your questions. All right, with that said, I want to tell you a little bit about our fabulous speaker today. She is Ruth Benka. Dr. Benka is professor and chair of the Department of Psychiatry and Human Behavior at UC Irvine. She received her AB at Harvard and her MD and PhD degrees from the University of Chicago. Dr. Benka has been a faculty member at the University of Chicago and the University of Wisconsin-Madison, where she was associate chair of the psychiatry department and the director of the UW Center for Sleep Medicine and Sleep Research. She moved to UC Irvine in 2016, where she's established a sleep medicine center providing clinical care for sleep disorders, as well as promoting translational research. Dr. Benka's research focuses on the interface between sleep and psychiatric disorders across the lifespan and the role of sleep and sleep disorders on Alzheimer's disease. And I know that, this is going to be great information for all of us, but especially for our senior care professionals and administrators of RCFEs, because, a lot of our residential care facility residents have problems with their wake sleep cycles, and so and we can all benefit from understanding those impacts on sleep. And so we're really looking forward to this today. Her research focuses on the interface between sleep and psychiatric disorders across the Oh, I said that already. I'm sorry. She served as principal investigator for studies funded by agencies including the NIH and the DoD. Her work has spanned basic research in animal models to clinical research and clinical trials. She's authored over 150 articles, reviews, and book chapters. She served as president of the Sleep Research Society, and she served on the board of directors of the American Academy of Sleep Medicine. She's currently editor-in-chief of Current Sleep Medicine Reports and Insomnia section editor of Up to Date. So it gives me great pleasure to introduce you now to Dr. Benka and to turn the presentation over to her at this time. Welcome, Dr. Benka.
Thank you so much, and it's a pleasure to be here with you, and thanks for so many people for showing up today for this. So we're going to talk today about the importance of sleep. I'm going to try to focus a little bit of my talk around issues related to Alzheimer's disease and also to COVID, since we're all grappling with that right now. All right, let's see if I get this working. Okay, so first of all, sleep is an incredibly important behavior. We spend a portion of our life asleep. Over a third of our lifetime is spent sleeping. And we generally understand how important sleep is for our physical and emotional health. And we're gathering more and more data as time goes on about how sleep disturbances and sleep disorders can impact on pretty much all aspects of our health. So how much sleep do we need? That really depends mostly on how old we are. And as we're all hopefully somewhat familiar, newborns and young children need more sleep. And as we get older, we likely need less sleep. However, most of us are not getting as much sleep as we probably require. And I want to just show some of these numbers here. So adults, anywhere between 18 and 64 years old, most of us would need 7 to 9 hours of sleep, with some individuals needing more and some able to get by with a bit less, but that is not the majority of people. And even in elderly individuals over 65, we need at least 7 to 8 hours of sleep ideally. Some people can get by again with a bit less, and some people may need more. But as we actually look at data, we find that a very significant number of individuals in the US do not get the sleep they need. And as we look at surveys from about 1990 onward, we see that at least 40% of people are getting 6 hours or less of sleep, and this is across adults. Now, if you look earlier, here's 1942, it was only 11%, and those of us who can remember earlier years like the 50s or even the 60s, the society has really changed a lot since then. So back then, there was no television broadcasting after about 10 o'clock or so at night. Stores and businesses were not open 24 hours as they are now, and certainly didn't have late night hours. And we've really developed into a 24-hour society, which allows people to do a lot of things at night instead of sleeping. And so we have really short-shrifted ourselves, and this is having a lot of health consequences for us. Well, there are a number of different causes of sleep loss. And of course, first and foremost is sleep deprivation, where we don't give ourselves an adequate opportunity to sleep. Again, having the internet available all night, television, our iPhones or whatever, and activities that are open all night can contribute to this. Also, various types of sleep disorders can contribute to sleep loss, like insomnia. And insomnia, as we'll talk about in a little bit, is not the same thing as enforced sleep deprivation. It's just having trouble sleeping, which can lead to reduced sleep amounts. And other sleep disorders like sleep apnea, which is a breathing problem during sleep, which I will also talk about, or sleep timing disorders like circadian rhythm disorders, where we can't sleep at the right times of day. There are quite a number of health risks for people who are chronically sleep deprived, meaning that they, for prolonged periods of time, do not get as much sleep as they need. And some of these side effects can occur even just with an occasional night of insufficient sleep, particularly things like being irritable, having mood dysregulation or depression. We know that people who have slept insufficiently, because then they'll have excessive sleepiness during the daytime, are more likely to have accidents or injuries like falling asleep at the wheel, having problems with memory and attention. For those who are chronically sleep restricted or sleep deprived, we know from epidemiologic studies that there is an increased risk of cardiovascular disease, of diabetes, and of obesity. Interestingly, studies done across the lifespan show that everything from young children to older adults who sleep less tend to weigh more. And this is probably in part mediated by the fact that sleep deprivation changes your sort of appetite regulation to seek out high reward foods. So things that are very high in calories, high fat, high sugar, high salty foods. And if you kind of think about it, what are the things that people snack on late at night? It's, hitting the freezer for the ice cream, or getting the cookies or the chips out. People are not going scrounging in their refrigerators for the carrot sticks and celery. We also know that chronic sleep loss increases the risk of infectious diseases, and I'm going to talk a little bit more about that because this is certainly a critical issue during the COVID pandemic. And finally, people who have short sleep have an increase in all causes of mortality. They don't live as long, and these studies have been done in a variety of species. Even short sleeping fruit flies have shorter lifespans than those who sleep longer. Again, focusing a little bit on sleep loss and immune function, because we're all, particularly attentive to this now with the COVID vaccines coming out and just dealing with the infections, is that when we are sleep deprived, our immune responses are diminished. So things like natural killer cells, which are the surveillance cells that kind of go around and will remove things like newly forming cancer cells, are reduced. There is increased inflammation in the body in general, which is not necessarily good, and probably also contributes to things like dementia. Studies that have been done looking at how people respond to vaccinations have shown, in studies done with influenza vaccines, that if you're sleep deprived around the time that you get a vaccine, you're not going to mount as good an immune response or make as many antibodies as if you sleep more. And again, critically important as we're all trying to get our population vaccinated to the COVID virus. And finally, there's other evidence of increased inflammation. There's actually a bidirectional relationship between sleep and the immune system. Each one affects the other. And I think one of the ones that we're all familiar with, if you've ever had an infectious illness, a virus or a bacterial infection, you know that when you're sick, you're fatigued, you're lying around in bed all the time, but your sleep is really disturbed and fragmented. And that's because substances that are produced by our immune system responding to microbes, bacteria, and viruses, these inflammatory molecules affect our brain function and sleep. Conversely, the sleep is really important to mount a good immune response. As I mentioned earlier, if we don't sleep sufficiently, then we're not going to mount as good a challenge to an infectious process. So it can be kind of a vicious cycle. Sleep is also very important for learning and memory. And these are some of the things that in particular we're studying at UCI, pretty much across the lifespan, how sleep is critical for memory functions. And one of the things that happens during sleep is what allows us for our brains to change day to day as we learn new things. So during the daytime, whether we know it or not, we're always learning things, we're experiencing the world. Those memories are consolidated during sleep. We transfer memories from long-term to from short-term to long-term storage, and the next day we are better able to recall that. And again, in some of the studies we've done in both adolescents and older adults, we find when we give people learning tasks before they go to bed and then test them in the morning when they wake up, that the performance is highly linked to how they've slept during the night. A similar thing is going on in our immune system. So during the daytime, our immune cells are encountering and taking up antigens, viruses, bacteria, other foreign substances in our body. They are transferring this information over the night, and then we have a better immune response the next day. And again, some of the processes are interfered with if we don't get enough sleep. And it does seem to be that our deep, slow wave sleep is important both for memory consolidation in our brains, as well as some of the important immune functions. We'll now start talking about some of the sleep disorders I think that are particularly relevant both for the public at large as well as for our Alzheimer's patients. And one of those disorders, very common sleep problem, is insomnia. And insomnia consists of several components, which can include trouble falling asleep at the beginning of the night, frequent awakenings during the night, which can be short or prolonged, but they fragment and disrupt sleep, and or waking up earlier than desired in the morning and having trouble getting back to sleep. In addition, most people with insomnia will perceive that their sleep is just really not of good quality. It seems not restorative. We rarely have people who say, I have trouble sleeping at night, but my sleep quality is great. Usually those go hand in hand. There are a number of risk factors for insomnia, and first and foremost is age. The older we get, the more likely we are going to have insomnia symptoms. Women have more trouble with insomnia than men, particularly as they get into the peri and postmenopausal years. And as we're going to talk about a little bit later, insomnia is a risk factor for Alzheimer's disease. And so one of the intriguing questions is, are women more likely to have Alzheimer's because they have more insomnia? Various types of stressors like loss of significant relationships because of divorce, separation, or loss of a partner can increase insomnia. Psychiatric illnesses, medical conditions, smoking, substance use like alcohol, coffee, and certain prescription drugs. And finally, one of the things we've learned recently is COVID has been a huge risk factor for insomnia, in that insomnia rates have really skyrocketed through the pandemic. There are a number of factors that contribute to insomnia, and those include predisposing factors, meaning that some individuals are just a little bit more stress prone to begin with. They're sort of wired to react more strongly to stressors. Precipitating factors are generally stressors, and all of us at some level of stress, will start to kind of have a response of not sleeping as well. And again, chronic stressors can perpetuate insomnia, as well as certain types of behaviors that may be counterproductive to getting a good night of sleep, like spending too many hours in bed. So we'll talk about that as well. There are a number of health risks of insomnia. I'm starting with the two, again, that are most relevant during COVID and pandemic, which is respiratory infections and decreased immune responses to vaccinations. Insomnia, as we know, is a very significant risk factor for major depression, and the individuals who have chronic insomnia are at a much greater risk of eventually developing a mood disorder such as depression than people without insomnia. We are also now understanding that insomnia is a risk for suicidal ideation and suicide attempts. Again, during the pandemic, we are having pretty much an epidemic of suicide, along with epidemic symptoms of anxiety, depression, and sleep problems. But individuals who have profound insomnia are far more likely to think about suicide or attempt suicide. Again, as I mentioned earlier, similar to chronic sleep deprivation, chronic insomnia has been associated with cardiovascular disease, increased risks of stroke, increased risk for type 2 diabetes, increased risks of cancer, and increased risks of Alzheimer's disease. So how do we treat insomnia? So first, I think, it's just important to keep in mind that insomnia is not a trivial problem. I think it tends to be kind of swept under the carpet because it's sort of like, well, that's not really all that important because we're not understanding how important sleep is to our health. So when we evaluate and treat insomnia, the first thing we do is we try to understand what kinds of other conditions may be present, because insomnia rarely travels alone. It is most commonly, over 90% of the time, found in people with other medical and psychiatric conditions like psychiatric disorders, chronic pain, sleep apnea, which we'll talk about, and other chronic medical disorders like cardiovascular disease, pulmonary problems, cancer, et cetera, and with primary sleep disorders. So we want to make sure those conditions are adequately treated because they are likely contributing or exacerbating the insomnia. And I very frequently, when I see patients in clinic, they have one of these other conditions present that is not sufficiently treated. They're still in chronic pain, they have depression that isn't adequately treated, et cetera. And it's hard to treat an insomnia without also treating those conditions. We next promote good sleep habits or good sleep hygiene. I'm going to talk about that in a moment. But this is a very important point, which is that good sleep habits or good sleep hygiene are not a sufficient treatment for chronic insomnia. And oftentimes patients get very distressed because they know they're trying to follow good sleep habits and they're still having insomnia, and then they become more concerned that there's something seriously wrong. And one of the things is that the good sleep habits are sort of the baseline from where we have to start. Having good sleep habits means you're not doing more things that are going to contribute to insomnia, and rather we can sort of start from there and then go to something that is going to be effective, like cognitive behavioral therapy. Now, cognitive behavioral therapies include a number of techniques to help patients improve their sleep at night, both dealing with negative cognitions about sleep and having other types of behavioral treatments that will help patients relax and get more consolidated sleep. We know that these treatments are effective, and in fact, the evidence is that cognitive behavioral therapy is more effective than medication, certainly than medications alone. And sometimes we combine medications with cognitive behavioral therapy. So let's talk about what the good sleep habits are to begin with. And this is, these are good habits for anybody, even people without sleep problems, which is first to have an appropriate amount of time reserved for sleep each night, ideally at least 7 to 8 hours. The activities during the daytime are critically important. I always like to say the quality of your sleep at night depends on the quality of your waking life during the day. And so it's very important to have a regular schedule for things like sleep, your meals, work, social activities, exercise. Our sleep is partly regulated by a circadian rhythm or an internal clock, and that clock is set by all the things that we do during the day, and mostly by daylight exposure, which is the third point. Try to get daylight exposure during the day to regulate your sleep and circadian rhythms. Ideally, if you're having trouble falling asleep at night and trouble waking up in the morning, get morning light, but anytime during the daytime, and we're very fortunate in Southern California that except for the periods of May gray and June gloom, we still get plenty of daylight and plenty of daylight later in the day. Avoid electronics and bright light exposure near bedtime because that can be alerting. Ideally, we should have about an hour or so to do something relaxing before bedtime. It's very hard to fall asleep if you have been in a high stress situation or, cognitively or emotionally challenged right before you go to bed. So you want to do something that allows you to sort of calm down, settle down, and relax before bedtime. Get up at the same time every morning, regardless of how much you sleep. Avoid napping if you have insomnia, but if you don't have insomnia, older adults without sleep problems sometimes feel better if they have a short nap in the middle of the day. And finally, particularly during this time of a lot of stressors, to realize that a short bout of insomnia is a normal reaction to stress. But if you have persistent problems sleeping, to check with a healthcare provider, start with your primary care provider to prevent short-term or acute insomnias from turning into long-term or more chronic problems. We talked about sleep hygiene or good sleep habits. And then the next step is cognitive behavioral therapy, as I mentioned. In the past, it was usually provided by trained therapists, but there is a problem with access. We don't have a huge number of therapists available to do this work. So we are now with again, with COVID, we've been learning we can do a lot of things online. And we have some other approaches. We know that these treatments, again, are effective, but even the computer-based ones can work for many people or be helpful. There are a couple of examples, one of which is Sleepio. Sleepio has been tested in patient populations as effective. That has a fee for its use. Another one, Somrest, is also similar, but this one is FDA approved and unfortunately requires a prescription from your physician, also has a fee attached. But there's a free app you can get from the Veterans Administration called CBTI Coach. And you just go online and download that, and that has been helpful for many patients as well. And if these don't work, you can get more personalized help from a therapist for these treatments. And next slide. There are quite a number of medications that have been FDA approved for treatment of insomnia, and the American Academy of Sleep Medicine has also put out some guidelines in terms of when these medications should be used. And I think the main issue is that we choose medications for insomnia based on the class of drug, depending on what it does, and its duration of action. So if people are only having troubles just falling asleep at the beginning of the night, we'll use a very short-acting medication just to help them get to sleep. If they have trouble during the night or later in the night, we may need a longer-acting medication. Most of the medications that we've had, so everything starting at the top from temazepam down through zolpidem, these are drugs that act on the benzodiazepine receptor, so they are either benzodiazepines or related drugs. They are controlled substances, and we try to avoid their use in people who have had any problems with substance abuse. They are also, as a class, generally not recommended for use in people over the age of 65 by the Beers criteria. We have a couple of other agents that work by different mechanisms, and these have been tested in older adults, including Ramelteon, which is a melatonin receptor drug. So it acts like melatonin, and melatonin is a hormone that your brain secretes that tells your brain it's night and you should do what you do at night. And that is not a controlled substance. Doxepin is been kind of remarketed in a very low dose as a sleeping medication. It's actually a tricyclic antidepressant, but it has a very strong antihistamine effect and seems to be sleep promoting. Again, these drugs have been tested in older adults and have been found not to have significant side effects. And then the newest kind of entrance to the hypnotic armamentarium have been drugs that work on the orexin system or orexin receptor antagonists, including suvorexant and lemborexant. These drugs tend to be a bit more long-acting, and the orexin is a neurotransmitter, a neuromodulator in your brain that helps to keep you awake. And the sleep disorder narcolepsy, where people keep falling asleep all the time, is caused by a lack of orexin. So this drug basically blocks orexin during the night and allows you to stay asleep or get back to sleep more quickly. So it decreases wakefulness. And both of these drugs have been tested actually even in patients with Alzheimer's disease. Suvorexant does have an indication for insomnia in Alzheimer's. Lemborexant has been tested in patients with dementia who have irregular sleep-wake patterns or non-24-hour cycles. So again, we're starting to get more data for use in this population. Next, please. Okay, sleep apnea, turn to another disorder. Sleep apnea or sleep breathing problems at night. This is a very common disorder, particularly in aging, and it is extremely prevalent in Alzheimer's disease. It's estimated that about 3/4 of institutionalized patients with Alzheimer's disease have sleep apnea. And what happens in sleep apnea is that the airway at the back of the throat closes, kind of in the picture with the red arrows. And so as you try to breathe in air at night, the more you try to suck in air, the tighter that airway closes. It's like putting your finger over a straw and sucking in. We all did that as kids. The air isn't coming in, and as a result, the patients keep trying to breathe, but they're not bringing enough air into their lungs. Oxygen saturation drops, and then a signal goes off in the brain that oxygen levels are low, you better wake up and take a breath or two. Patients with sleep apnea have, next slide, typical symptoms. Side effects of sleep apnea, these repeated respiratory pauses that cause drops in oxygen level and frequent arousals. We're going to talk a little bit more about this, but we are now recognizing that people with sleep apnea are at increased risk for bad outcomes with respiratory diseases like influenza and particularly COVID-19. People with chronic sleep apnea also have increased risk, particularly when it's not treated, of cancer, high blood pressure, coronary artery disease, arrhythmias, particularly atrial fibrillation, to the point that pretty much we test everybody with atrial fibrillation for sleep apnea. Cognitive impairment and dementia. Obstructive sleep apnea increases the risk not only for Alzheimer's disease, but also vascular dementia and all-cause dementia, increased risk for strokes, for metabolic disease, and for all-cause mortality. Obstructive sleep apnea, as I mentioned, is associated with poor outcomes with COVID-19 infection. People with apnea are at increased risk for ICU admission, for dying from COVID. And we know that the risk factors for poor COVID outcomes are exactly the same as risk factors for obstructive sleep apnea, which includes being older, being male, being obese, so BMIs over 35, and those are all high risk factors for having sleep apnea, and other comorbidities like chronic obstructive pulmonary disease, high blood pressure, coronary artery disease, and diabetes, which are also all risk factors for apnea, are risk factors for poor outcomes from COVID. And so the fact that people with sleep apnea are already dropping their blood oxygen saturation at night due to their apnea, when they on top of that have another lung disease like COVID that is decreasing their ability to get oxygen into their system, it's not surprising that the outcomes are far worse. So this is another reason why it is really imperative for anybody with sleep apnea of any age to make sure they get vaccinated and get their apnea treated. Okay, now next slide. So common symptoms of apnea are daytime sleepiness, loud snoring at night, and witnessed apneas. Often it's loud snoring, a breathing pause, and then a loud snort or gasp with continued snoring. Other symptoms can include insomnia, because sometimes people are not able to sleep because they keep waking up, waking with headaches in the morning, frequent urination at night, reflux, because when you can't breathe and you're trying to suck in air, you're also pulling up gastric contents, so gastroesophageal reflux is worse, mood disorders, cognitive complaints, and sometimes people don't have any symptoms at all, but may have risk factors such as being male, elderly, and overweight. So how do we diagnose sleep apnea? Really, there's no way to diagnose it other than doing some type of sleep laboratory testing. The gold standard used to be that we would put everybody in a sleep lab, but these days we do a lot of home sleep tests where patients can pick up the equipment, put it on at home, and bring it back the next day, and we can do a very adequate job of diagnosing sleep apnea that way. Treatments include continuous positive airway pressure, which is really just blowing some warm, moist air in the nose. It's a very safe treatment. It keeps the airway open. For milder cases, we can use oral appliances, which help pull the jaw forward. In certain cases, like children with big tonsils or adenoids, we can do surgery, and weight loss can be curative when it's due to patients being overweight. I'm going to skip a couple of these, but we're going to start talking about sleep and dementia. Why don't you skip over, because I know we ran a little behind with the technical difficulty. Stop. Okay, so what we're going to do here is we're focusing now, and we've been making progress a bit on decreasing dementia risk by eliminating risk factors. And we know that some of those factors pointed out in this slide are when we're young is to get more education. So education is a mitigator for Alzheimer's risk. In our middle years, trying to prevent head injuries, limiting alcohol use, trying to treat hypertension, preventing obesity, and treating hearing loss are all factors that can decrease or slow dementia. And finally, in later life, treating things like depression and diabetes, and making sure people don't smoke, aren't exposed to air pollution, aren't socially isolated. Again, a problem now during COVID. Those things will help. But in this Lancet Commission article, there was no mention of sleep. And as I want to point out, sleep disturbances and sleep problems are also important risk factors for Alzheimer's. Next slide. So there are some changes that occur with aging. As I mentioned earlier, sleep amounts decrease with age. Older adults may need less sleep, but it's also the case that we are less able to sleep as we get older because there are some changes in our brain structure and our rhythms. There are increasing levels of medical and psychiatric illness that we develop as we age. We're taking more medications that can affect our sleep, and we're at more risk for sleep disorders. So there are a lot of factors that may make it harder for us to get the sleep we need. So there's a lot of evidence that sleep increases our risk for Alzheimer's, and I'm just going to go to the bottom line in the bold here. Various analyses of studies that have been done suggest that at least 15% of the risk for cognitive impairment or Alzheimer's is directly attributed to sleep problems. So another meta-analysis of 18 studies of almost 250,000 people has shown, again, that various types of sleep problems, including insomnia, sleep apnea or sleep disordered breathing, and general sleep problems all of those contribute to Alzheimer's. And both sleep disordered breathing and general sleep disturbance contribute to all-cause dementia, and vascular dementia is exacerbated or increased with sleep apnea. And there's a very specific link between insomnia and Alzheimer's disease. Keep going. All right, so we know sleep problems are more severe in patients with Alzheimer's disease and may include a loss of rapid eye movement or REM sleep, and also sleep timing problems, so problems with circadian rhythms, that patients with dementia are dozing off during the day and they can't stay asleep at night. And the worse their cognitive impairment, the worse their sleep, the worse the cognitive impairment, the more caregiver burden there is, and it increases their risk for being institutionalized. There's a recent study that just came out that many of you may have seen, following almost 8,000 people for 25 years, where they found that people who slept 6 or less hours at early ages were far more likely, at the initial thing, were far more likely to develop Alzheimer's disease. There are a lot of interactions between Alzheimer's pathology and sleep. So we know, of course, Alzheimer's is caused by the accumulation of beta amyloid plaques and tau protein tangles. We know that sleep, and particularly deep sleep, is important for decreasing clearance of amyloid and tau at night. Those substances are produced during waking, they get cleared out during sleep. So if there is sleep disturbance or disruption, you're not going to clean up the brain as well. So what we call, I like to say, sleep is important for brainwashing. Conversely, we know that amyloid deposition disrupts sleep. And we've done several studies looking at people who were at risk for Alzheimer's. These are relatively young people in their early 60s. And we've asked them questions like, how often do you get enough sleep in the morning to feel rested? And how often do you get the amount of sleep you need? And the more they responded negatively to these items, the more evidence we found for Alzheimer's pathology. We found that both using PET scan studies and also looking at cerebrospinal fluid biomarkers, that worse sleep was associated with increased evidence of amyloid deposition or amyloid and tau pathology. So these are people who were still cognitively intact, but they started showing evidence of Alzheimer's pathology related to poor sleep. Next slide. And some of the work we've just done, and this is, I think, near the end here, is we've been, again, looking using what we call high-resolution EEG, so putting a net of electrodes on the scalp and looking at the appearance of sleep-related brain waves. And we have found older adults in their early 60s who are generally cognitively intact, but at increased risk for Alzheimer's disease and are amyloid negative, that sleep spindles, which are a particular sleep oscillation that is involved in learning and memory, are decreased in relation to tau deposition, and that people who have this tau-related reduction in sleep spindles have poor sleep-dependent memory when we give them a learning task before they go to bed and then test them on it the next morning. And we think this appears to be related to inflammation. So inflammatory processes very early on are contributing to decrements in sleep brain waves and in cognition, even before they're grossly detectable. And this is some of the work that we're continuing here at UCI. So I think that's, the next slide should be questions, and one more slide and you can go on to the final question. So any questions? We still have a few minutes to get to some of those.
Okay, great. And I just real quick want to ask you, did you say that 3/4 of Alzheimer patients are found to have sleep apnea?
Of institutionalized patients, yes.
Okay. And
When they're at the point of
I was stunned by that, and I was just thinking about if they were all treated for that, how much their functioning might improve and
yeah,
their
this is
day-to-day quality of life, and how much easier they would be able to be cared for. I mean, I
well,
think that would be something that RCFE administrators and nursing home administrators would be so interested to know if they were tested and found to have apnea. I mean, it's just that kind of rocked my world to hear that. I didn't know
yeah,
that,
the
but
real issue is what, and some of the things we're studying is what happens if we take people with apnea who are at risk of Alzheimer's and treat it before they become
oh, obviously,
cognitively impaired.
yeah,
That's really
I've
what we're
had,
trying to do.
I've actually, obviously, yeah, I've had clients like that, that
Mhm.
upon, treatment of apnea resolved their Alzheimer's symptoms, which is a fabulous story. But I, I've got to get back to the business of the webinar here. But that, I mean,
Yes,
that's just wonderful, wonderful. This has been such a valuable topic and such useful information, Dr. Benka.
thank you.
So you, the audience should be typing questions into the question box if you haven't done so already, and we're going to get to those in just a few minutes. But in looking at the timing, I do want to pause for a second and just remind everyone who's seeking CE credit that they need to stay online for a full 60 minutes in order to receive that, and that when we do close out of the webinar, eventually, you will get your pop-up evaluation, which of course has to be completed as well in order to receive your CE. Before we get into the questions and answers, I do want to take a moment to thank our sponsors again. It's just so wonderful to receive these free webinars with such great information month after month. And so we thank O'Connor Mortuary, Care Choices, Hospice and Palliative Services, and Comparing Companions at Home, as well as Alzheimer's Orange County for that. I also want to have you take note of our next webinar, which will occur on Tuesday, June 8th at 11:30 Pacific time. And the topic is supporting LGBT older adults. And we have a fabulous speaker from SAGE, Dr. Tim Johnson, and he's the Senior Director of National Projects there at SAGE, Advocacy and Services for LGBT elders. So let me, at this time, then get back to, let me open the question box and see what we have for Dr. Benka. Bear with me for just a moment and let me scroll through and see what's going on here. Is there any way to test or regulate circadian rhythms?
Sure. So actually testing is pretty easy. We generally just have people start out by keeping a sleep log. And if we look at sleep patterns over several weeks, so we're talking about a rhythm that is about 24 hours, so we need several cycles. And we generally like to get about 2 weeks of data. And by looking at that, we can sort of detect what's going on. Another thing we can do to measure rhythms is use something called an actigraph, which is a rest activity monitor. Actually, a lot of smartwatches and Fitbits have those as well, and we can sort of see how the sleep is lining up. And then in terms of treating circadian rhythm problems, we really focus on interventions that are going to stabilize circadian rhythms, which is appropriate timing of light. So one of the most common problems is what we call a delayed sleep phase, where people are night owls and they can't fall asleep until 2 or 3 or 4 in the morning, and then they can't get up in the morning. And so what we do is we expose people to bright light early in the morning when they wake up, and we try to help that move their schedule back. And again, as I mentioned, having regular timing of things like meals, exercise in the morning also would be helpful. We can use melatonin in the evening to help deliver that signal. So there are a variety of behavioral approaches that we can use with scheduling, light exposure, melatonin, et cetera, to re-entrain people to a more normal rest activity pattern.
Fabulous. This question has to do with medications. There's a lot of information on the damage that insomnia does to our health and brains, but there's not a lot of information on the long-term effects of using sleep medications to help with sleep. Can you comment on this, please?
I think, again, the strongest evidence for treating insomnia is really with cognitive behavioral therapy. And unfortunately, that's not as widely available or as widely used as it should be. In terms of medications, most studies that have been done looking at sort of the risks and benefits of sleeping medications sort of come down as, well, there's weak evidence that they're probably more helpful than they are harmful. Now, that's not to say that they can't be beneficial for many patients. And, for each individual, it's sort of a risk-benefit assessment. What we recommend is behavioral approaches that may be combined with medications. And certainly when we start dealing with people with cognitive impairment, with Alzheimer's disease or other dementias, we often need to use a combination of medications plus behavioral approaches. And behavioral approaches include sensory stimulation, light exposure, physical activity during the day as much as possible, and, quiet and dark during the night, perhaps medications as well. But again, the medications that can and should be used in older adults are not necessarily the same as the ones that we can use in younger adults.
Have there been any long-term studies of insomnia that include 24-hour, multi-day, or week research and include regular blood tests and brain monitoring to look for biological reasons for insomnia?
Oh, yes, there have been lots of studies done. What most of them have concluded is that insomnia is related to kind of hyperarousal. The brain does not quiet down properly during sleep. I've been involved in some work that has shown that brainwave activity during sleep in people with insomnia shows parts of the brain are kind of more awake, particularly those parts that are involved in responding to sensory input. So that sort of kind of fits with people who, feel like the slightest little thing wakes them up and they have very light sleep when they're sleeping and have insomnia. So there are probably changes in brain wave patterns in people with insomnia, again, related to that their brain is not really as deeply asleep or as shut down. And there have been quite a number of other studies looking at physiologic effects of insomnia. Again, people with insomnia have more evidence of inflammatory responses. Their blood pressure doesn't dip the way it should at night. So there are physiologic effects of insomnia, again, mostly related to hyperarousal. And that's another thing, is that even people with insomnia who report feeling very tired during the day are actually not sleepy. They can't sleep at any time of the day.
Oh my gosh, that sounds awful. We have someone asking about the use of CBD or somatic/breath exercises. What are your thoughts on those?
What was the second thing?
It says somatic, or is that supposed to be semantic? I'm not sure. /breath exercises.
Okay, so
exercises.
yeah, breathe. Okay, so the whole issue with CBD and marijuana is still kind of up in the air. There's not a lot of strong evidence yet that it's all that helpful, although there are some studies going going on. I know UCSD is, I think, doing a study on CBD for sleep. One of the problems with THC and marijuana products is that while they may help sleep, it's very hard to get off of them, and then sleep is very disrupted when you stop. It's sort of like alcohol. Alcohol might help you sleep, but then for people who use alcohol chronically to sleep, even through periods of abstinence, their sleep can remain very disrupted. So we have to be a little bit careful about that. In terms of, I'm not sure what the breathing thing is, but there are certainly various relaxation techniques that can include breathing that are helpful for some people. And in a multi-component cognitive behavioral therapy, breathing exercises may sometimes be included for patients. I think the issue with behavioral treatments for sleep, and there are a lot of different modifications. So there are, for example, mindfulness meditation has been adapted for insomnia and been effective for some patients. And there's, I think there are other approaches of other types of therapies, behavioral therapies that have been adapted. So it's really to choose one that you feel you can do, because if you can't do it and practice it properly, it's not going to work for you.
Right. Thank you. Then we have someone that has a couple things going on with herself and her partner at night. One is muscle cramps, and the other that wakes them up, and the other is frequent urination. Any suggestions?
Well, both of those can increase with age. Muscle cramps are different. Are not a sleep disorder per se, but they can be quite irritating. I think you might want to check with your primary care doctor. Are you on any medications that might exacerbate that? So things like diuretics or things that cause dehydration can cause muscle cramps. Electrolyte imbalances could do that as well. In terms of frequent urination, again, is this a male who's having prostate issues that need to be treated? Frequent urination can also be a sign of untreated sleep apnea. It can be a sign of, diabetes. So it's, again, I think that would be something that I would check with your primary care doctor about. Certainly, if you have frequent urination, and it's not uncommon for me to see patients like that, you're not going to sleep well because it's going to keep waking you up at night. Or you taking a diuretic medication that is causing you to urinate frequently at night. So again, that probably needs a little bit more specific assessment in your particular situations.
Here's an interesting question, Dr. Brinka. If a person is accustomed to working nights, like an RN, for example, on a regular basis, does that increase their risk for dementia in later life? That's kind of fascinating when you think about the circadian rhythms and everything.
I'm not sure that I don't know that there's evidence of night shift work increasing dementia. We do know that shift workers do have some increased health risks. I think it's a little controversial, but there have been, that they have more GI disturbance. They may have more tendency to gain weight, again, because of the disruption of sleep. Increased risk. There's been some controversy in some nurses' studies that they have increased risk of breast cancer. But basically what happens is even when you're working night shifts, your clock in your brain can't adjust exactly as long as you're exposed to daylight when you're not at work. And so, for example, things like space shuttle astronauts have to be really in kind of almost hermetically sealed environments to shift. So they usually send a crew up that's one half is shifted to be up at night and the other half shifted to be up during the day. But most shift workers don't fully accommodate because, we're not wearing dark light blocking goggles during the daytime and just being up at night. So yeah, there are some increased health risks that are associated with shift work, but that doesn't mean everybody will get them, but on the whole, probably a little elevated risk.
Would you say that their quality of sleep has got to be diminished relative to sleeping at night? I guess
yes, it can be. Yeah, it can be. So we know that about 10 to 15% of people have what we call shift work disorder, which means it's just extremely difficult for them to be awake during the night when they need to work, and then it makes it very difficult for them to sleep during the day. And so we can treat shift work problems, and then a large bulk of people who do shift work will have kind of lesser symptoms, but still trouble sleeping during the day when they're off of their night shift, and trouble staying awake during the night, particularly in those early morning hours. Again, if that's an issue, there are medications that we can use to help people stay awake during their shifts that are relatively safe, and also sometimes we can give some mild medications to help sleep during the daytime so they don't get sleep deprived. Because if you're sleep deprived, it's even harder to go back to a night shift, because then you're really going to have trouble staying awake.
Sure, that makes sense. Do you get the same benefits from a chemically induced sleep compared to a natural sleep?
That's a complicated question. I don't think I can say no. It depends on the drug. So these are still things we're learning about in terms of what medications do to your sleep brainwaves. It is another thing that we're studying here at UCI. Certainly, I would say on the whole, you're better off if a mild sleeping medication helps you sleep better and feel better during the day. You're probably getting better quality of sleep than you were without a medication. But we also try to help people who don't have, who are otherwise generally healthy, to learn how to sleep better, because sleep is a learned behavior as much as it is just something that automatically happens. Again, that's different in people who have neurodegenerative disorders, where their brain systems that are regulating their sleep and waking are not functioning as well. That in those cases, we may need medications to help improve sleep quality and waking quality.
Okay. I'm just trying to be mindful of your time now. It's
I'm fine.
12:40. We have run
A couple more
over.
minutes. If there are a couple more questions, I'm happy to
Okay,
take them.
let's take one more question before we close. Let's see. And I apologize. I know there are more questions here, but I have to be mindful of your time and everyone else's. If you sleep in 2 segments separated by 2 hours, but cumulatively get 7 to 8 hours per night, is that okay? Is that considered enough sleep? So it's
Sure.
breaking it into,
Yeah. So, normal human or primate sleep is really 2 chunks of sleep. So the first part of the night, you sleep because you're sleep deprived, and that's where you have more of your deep, slow wave sleep. And then the second part of the night, you sleep in the early morning because your circadian rhythm is making you sleep then, and you have more of your REM sleep or your dreaming sleep. And hundreds of years ago, actually in the 1800s, before there was electric lighting, people actually used to have kind of 2 chunks of sleep. And even more recently, when studies were done where they put people in bed for longer periods of time, sleep will sort of separate out into these 2 chunks, generally with a period of quiet waking in the middle. I think the important thing is that if you wake up in the middle of the night, not to get agitated or stressed of like, oh, there's something wrong with me because I'm not sleeping. It's kind of the mirror image of what happens during the daytime. In the morning, you wake up because you're not sleep deprived. You've been sleeping, and then you have a siesta time where you want to doze in the middle of the afternoon, and then you wake up again in the evening because your circadian rhythm wakes you up. So your circadian rhythm wakes you up in the evening and causes you to sleep in the early morning. And that's what helps us generally stay awake during the day and generally sleep during the night. But again, sometimes, and particularly when we get older, and we might take a nap in the middle of the afternoon, and you might be awake for a little while during the middle of the night. But as long as you get enough sleep and you get 2 chunks of sleep, you should be okay.
That's great to know. Okay, well, thank you so much. This does bring us to the end of our webinar session today. We want to thank you, Dr. Banka, for that great presentation, for sharing your time and your expertise with all of us. To our audience, thank you for hanging in there with us.
Thank you.
through our little technical glitches. Everything, of course, worked out
Sorry about
fine.
that.
And thank you to our technician for advancing
Yes.
the slides,
Thank
as
you.
well as handling the polls and all the other things that always invariably come up in our little sessions here. So to the audience, watch for the survey that is going to come up and open up on your screen immediately when this webinar is, when I close it out. Make sure that you do complete your survey within 24 hours.
Oops.
And of course, we rely on all of you to fill out to submit your feedback so that we can continually make improvements to our programs. Let's see, what else? I talked
I
about the
wish
flyer.
everybody good sleep.
Yeah,
Wishing everybody good sleep. Yeah.
absolutely. And don't forget that if you're interested in any of our other many other educational programs, you can visit our website at www.alzoc.org to learn more about our educational programs and webinars, as I said, and to view past recordings of our other monthly webinars and other classes that we have. So everyone have a fantastic day, and we'll see you next time. Bye-bye.
Thank you.